We are going to talk about normocytic anemias with extravascular hemolysis, and we talk about sickle cell anemia. Now, sickle cell anemia, we have it is basically an autosomal recessive disease, and the thing to know it is that it is a point mutation, and we have two genes for it, two genes, right? Or you could just say, let's make it more simple and let's less terminology heavy. When we talk about hemoglobin, we have hemoglobin, we have heme, and then we have alpha, beta, right? That's that. And the problem in sickle cell anemia lies within the beta, not the alpha. Alpha was, with thalassemia. There is no sickle cell anemia in which we have alpha problem. We have beta problem in sickle cell anemia. Now, it's different from thalassemia, because it's a point mutation where the mutation lies. Normal hemoglobin is going to have valine, but in sickle cell hemoglobin, or HbS, sickle HB, we're going to have glutamic acid. Valine is hydrophobic and glutamic acid is hydrophilic, so which makes it sticky. And I'll tell you what that means in furthermore. So mostly, another thing that you need to know, that there are two types: sickle cell trait, and then we have sickle cell disease. Okay, sickle cell trait is when we have beta, one is okay but one is not okay. Okay, one beta is normal and the other is not. That's sickle cell trait. These people are gonna have somehow normal. They're going to be normal. They're going to be, sometimes they're asymptomatic or they have milder symptoms, right? But in sickle cell disease, we have both genes that are problematic, right? Another thing that you need to know, that they are protected against malaria. And this occurs mostly in the African descent people. So now, the thing is that now we get into the pathophysiology. The HbS, that is the hemoglobin in sickle cell disease, okay? The thing is that it can carry oxygen. Okay? It is able. It has the ability to carry oxygen. But the thing is that when it's deoxygenated, this boy is deoxygenated, that's the problem. When it's oxygenated, it is circular, spherical, right? Is a spherical disc, biconcave disc. But once it is deoxygenated, oxygen leaves it, it becomes sticky. HbS becomes sticky. Sticky means that there are many HbS's, and they will bind together. They are gonna stick together. And when all of these Hg's, like this is this red blood cell, these are Hb's right here. These are Hb's. These are oxygen carrying HbS. But when oxygen leaves, these are gonna get stuck together. And when they stick together, no oxygen, or deoxygenated, let's write deoxygenated, these are going to stick together and form a crescent shape. This is called a sickle shape, right? Like a sickle that you use for gardening, that looks like this, right? Or a half crescent shape. You can also say that this is sickle, right? That is the problem, guys. This is the problem. Because of on again, off again, oxygenation and deoxygenation, these cells will become spherical and then become crescent. Spherical, crescent. This puts a strain on the RBC membrane. So the RBC membrane damages, and when this damage, we all know, if you have done general pathology, when there is membrane damage, there's inevitable cell death. That is why this is a part of intravascular hemolysis as well, because the cell will die on their own, right? But also, a large amount of sickle cells, they're also getting, they're dying from intravascular way as well, but they are also going to die extravascularly because they're sickles. These are sickle cells. If you have a artery that is at a junction and you have a lot of sickles moving, right? These are a lot of sickles. They're gonna get stuck here at the junctions, and this occlusion is problematic. So this happens in spleen, and spleen then kills them. Then liver also kills them. The lymph nodes also kills them. So the reticular endothelial cells will remove the RBCs with damaged membranes, and that is going to lead to anemia. Right? So because of this peripheral destruction, there's going to be massive erythropoid hyperplasia. Same as happened in thalassemia. There was also massive erythropoid hyperplasia. So what are we gonna have? We're gonna have chipmunk faces. The facial bones are also gonna start doing erythropoiesis. They don't do erythropoiesis normally, but when there is hyperplasia, they're going to start doing it. And when they do it, we have chipmunk faces, and we're also going to have crew cut appearance of skull on x-ray, because the skull bones are starting doing erythropoiesis. Mind you, they don't do it normally. But if there is a parvovirus B90 infection, there are also going to be aplastic crises. When there's sickle cell anemia, and then they're going to have parvovirus, because they become immunodeficient when they are in case of sickle cell. And they're also going to be extramedullary hematopoiesis with hepatomegaly, which means that your liver is also going to start making red blood cells. That is called as extramedullary erythropoiesis or hematopoiesis, right? Which means your liver is going to start making RBCs. That is going to increase the size of your liver, or this is going to cause hepatomegaly, right? Now, as I told you above, there is going to be risk of vaso-occlusion. So there are going to be some certain signs, certain other conditions that you're also going to see because of vaso-occlusion. The first one is the dactylitis. Dactylitis is swelling of hands and feet. So swollen hands and feet. Okay. There is also going to be autosplenectomy. Your spleen is going to shrink or become fibrotic because it gets overworked. So autosplenectomy, which means you do not, splenectomy, is actually when you remove spleen, but automatically your spleen gets shrunken and fibrotic. That is, autosplenectomy. So automatic shrinking of spleen. Okay, cool stuff. What can it lead to? It can lead to encapsulation of strep pneumoniae, the bacterias, or Haemophilus influenzae. These are, removed by spleen, right? They are actually removed by spleen. But when you don't have spleen, then they, of course, get encapsulated. And then also there could be, because of spleen, out of splenectomy, there could be salmonella, osteomyelitis. Salmonella is going to cause osteomyelitis as well. So these are just infections that are going to be, they're actually prevented by spleen. And we're going to have Howell Jolly bodies. Actually, this is histology. I'm going to be detailing this in a future video with slides. Okay, Howell Jolly bodies, and also of previous anemias. When I tell you about peripheral blood smear, I'm going to do a separate video, and then it will be easier for you when you study all the anemias all together. It will be easier for you to picture and of course make a scheme out of it. So I'm not doing it right now. Okay, what else? We there could be a pain crisis. People with sickle cell anemia has a lot of pain, right? So unrelated to splenectomy, we have a lot of pain, patients. Then they're also going to have acute coronary syndrome, right? ACS. They're going to have ACS. They're going to have angina, chest pain. They could have myocardial infarctions, all because vaso-occlusion, because of vaso-occlusion. And of course, it is the most common cause of death, right? Chest pain, or when you have shortness of breath, or you have pulmonary microcirculation, when it clogs, the sickle cells clogs into the pulmonary microcirculations, you're going to have shortness of breath, and then of course it's going to infiltrate the lungs, and then that can cause death. And of course, renal papillary necrosis, because of a lot of hematuria and a lot of proteinuria, and that can become necrotic for the renal papilla. All right. So lab findings, we're gonna have sickle cells. So in labs, we're gonna have sickle cells. Okay, on the peripheral blood smear, and we are also gonna have there is electrophoresis. We do electrophoresis, and in electrophoresis, what do you see? You see HBS, right? And there is another test called as metabisulfite screen, and this actually sickles HBS. Okay, it sickles normal RBCs into sickle cells. Okay, so now the thing is that sickle cell will be only seen in sickle cell disease, not in sickle cell trait. Okay, not in sickle cell trait. Electrophoresis, the metabisulfite screen, it is going to be seen in both. Okay, and so for electrophoresis, that's left. In electrophoresis, when it's about disease, I'm gonna go there. If it's disease, sickle cell disease, we're gonna have 90% HBS. So these are the things that you approximate. 8% HBF, and then there is HbA2. You can see HbA2, but no HbA. Okay, and in trait you see 55% HbA, which is normal, 43% HbS, 2% HbA2. You don't see any HbF. And that is it, you guys. That is it for sickle cell anemia.